use discretion. I have the pleasure of introducing our speaker this morning. Dr. Michelle Wiedekan has been a PNP in the Division of Emergency Medicine at Cincinnati Children's since 2002, after she graduated from the PNP program at the University of Cincinnati. Prior to that, she worked as an RN since 1992 on an inpatient unit and then transferred to the emergency department in 1996, where she has been ever since. Michelle was promoted to APRN program lead in 2008 and now has 15 NPs who work for the division that she supervises. She works in both the main ED and urgent cares that are run by the division. She completed her Doctor of Nurse Practice in May 2015. She'll be speaking to us this morning on clinical practice guidelines. Are you current?
Good morning, everyone. I'm actually impressed by the number of people with it being St. Patty's Day last night, and everyone was out in their green, being here early this morning. So thank you for attending this session. And I also want to thank the Conference Planning Committee for allowing me to come and speak on clinical practice guidelines. I'm very passionate about making sure that we're following guidelines, especially as nurse practitioners. I think we have a great opportunity to be aware of what the guidelines are, stay up to date, and make sure that we're sharing this with our practices and within our colleagues, because nothing drives me more crazy than when I work in the emergency department or the urgent care and I see a patient that has been seen by a primary care provider or by another outside, mom and pop urgent care or another outside ED, and they treated a patient but didn't follow patient the clinical practice guidelines. And lo and behold, the child's not getting better. So that drives me nuts. So to start, I have no financial disclosures at all. And looking at the learning objectives, we're going to review some of the most useful sites for locating clinical practice guidelines and the importance for PNPs keeping current and up to date. We're going to also highlight the most recent clinical practice guidelines that have been introduced or updated in just the last couple of years. And I know there is some overlap with some of the other speakers that are out there, so I'm going to really try to just focus and summarize on some of the most important points. Some of my slides are very busy, but there's a lot of great information, but I'm also going to share where to find this information. And then we're going to summarize those points. So why should we follow clinical practice guidelines? The Institute of Medicine defines clinical practice guidelines as statements that include recommendations intended to optimize patient care that are informed by systematic reviews of evidence and an assessment of the benefits and the harms of alternative care options. For us, clinical practice guidelines are the recommendations for clinicians about care of our patients with specific conditions. They should be based on the best available research and evidence and our practice experience as well. So many of them will have not just the evidence from research, but it will have clinical experts that discuss or give recommendations as well. So there are a lot of different sites available for reviewing clinical practice guidelines, and I became a lot more familiar with these in my DNP program. I feel like I knew where some of the information was as a master's prepared nurse practitioner, but I did not realize the depth and the wealth of information until I did return to get my doctorate. And it became very clear where a lot of this information can be found and how important it is. So the National Guideline Clearinghouse is one of the sites. You can also go to AHRQ and link to many things. There is the Academy of Pediatrics, obviously. The CDC website has wonderful information on it. One of the best places to go find anything related to STD treatment. And then there's also the acponline.org. So again, you can also go to other places like savvysearch.com, Metacrawler, Google Scholar. There are things in PubMed that help you find clinical practice guidelines, quite a variety of things. So the things we're going to focus on today is we're going to look at bronchiolitis. We're going to talk about the guideline for respiratory illnesses in children and adults. We're going to talk about some of the latest information related to Group-BEsT strep, acute bacterial sinusitis for ages 1 through 18, clinical or community-acquired pneumonia for infants and children greater than 3 months. There's a new simple febrile seizure guideline that has recently been updated since 2011. There's also one about UTIs for children 2 to 24 months. And then just recently in 2015, there's a new guideline that came out related to the treatment of STDs. So I think it's really important to understand a lot of the definitions related to the evidence. So we have strong recommendations, and then we have recommendations, and we have the options, and then we have things that say this is not a recommendation. So you want to be very clear when you're reading about different clinical practice guidelines what those mean, and then they often grade the evidence as well. So when you have something that's graded A, that evidence is usually coming from a very well-designed, randomized controlled trial or diagnostic studies with a relevant population. That is often a very strong recommendation. It gets a strong recommendation A. Then strong recommendation or strong recommendation Bs usually are some randomized controlled trials, diagnostic studies, minor limitations, but there's overwhelmingly consistent evidence from observational studies. And then they also have some C recommendations, as well as there's the D recommendations, which is often expert opinions, case reports, and then there's also this X rating, and this is when there's some exceptional situations where validating studies cannot be performed. A lot of times this is based on children's ages and things like that, but there is clear evidence that there is benefit or harm related to something. We also have these things out there that are called best evidence statements. They may not have come up with the actual clear clinical practice guidelines, yet there are statements. And Croup is one of those that I have found that seems to have a best evidence statement. So Croup is, there's a best evidence statement that was developed by our hospital recently, in the last several years, and there's a very strong recommendation that you should give single-dose steroids, glucose steroids, administered to children presenting to the emergency department in mild, moderate, or severe Croup. So it's not just mild. So these are for the patients, though, that do present to the emergency department, is the recommendation. But I do believe that there is some good evidence that this could happen in private practice as well when you see them. The benefits related to this one is that glucocorticosteroid treatment in Croup has consistently demonstrated improvements in the syndrome and in the symptoms, and you'll see improved Croup scores. Often within 6 hours, there will be a decreased use of the need for epinephrine, decreased use or need for hospital stay. So there's definitely benefit in using things like Decadron, dexamethasone. All right, so bronchiolitis. Bronchiolitis is a big one that is, continually we see every year, day in and day out. This one is, the recommendations for this one, again, you want to make sure that you're getting, diagnosis is based really on history and physical exam. There is no test we can do for bronchiolitis. I love when the family comes in and says, my doctor sent me in for bronchiolitis to be checked for bronchiolitis. How do we test for that? And the families think there's a test. There's no test. We have to explain that to them. So you need to make sure that we are talking to families about supportive treatment. One of the really high recommendations that has come out from this latest guideline is that we are not to administer albuterol to these patients. And I still see families that go home with a prescription for inhalers, and then they come to the emergency room or to the urgent care and they say the inhaler's not working. The recommendation now, unless you really feel this child is not bronchiolitic and that the child is reactive airway disease, they're not supposed to be getting albuterol. There's no standard, the recommendation, evidence of the quality is pretty high. It's a B level, and it's a pretty strong recommendation. That's a big change. We went from chest physiotherapy back in the 90s when I first started as an RN for every child who had bronchiolitis and suctioning with deep suctioning, to now all we teach is, bulb suctioning and, using the nose Fritas And now we're even getting away from using albuterol. So that's really hard for people because families come in and they want that fix. They want a medicine. So, we really get away from it. If a family really feels that they need, there's a strong family history of asthma, we will trial albuterol occasionally in the urgent cares or the ED, but I'm telling you, most of the time, it doesn't work. There's no change in their wheezing. They continue to have wheezing. They continue to have some retractions. And as long as they don't meet the criteria for needing for admission, such as poor feeding, low oxygen saturation, and respiratory rate greater than 70, there's not a lot we can do for them. And we just have to, support the family, talk about suctioning, make sure they know when to come back. And there's a lot to the bronchiolitis guidelines. We're not going to spend a ton of time talking about it, but if there's a lot more related to admission and when do you use oxygen, and really they say oxygen you don't need unless it's greater than their oxygen saturation is less than 90%. There's not a strong, if they're going to go home, there's not strong evidence that this is going to help either. Making sure kids are getting lots of fluids is high on their list, and making sure too that they are well hydrated and they're not breathing too fast to suck, swallow, and eat. The guideline definitely stressed also prevention and education with families. All families should disinfect their hands. We need to talk about that with families. It's making sure that they're washing their hands after direct contact with their children who have bronchiolitis to try to decrease the risk of spreading to other family members. We are supposed to be using the alcohol-based rubs in the hospitals for helping with decontamination when we're caring for children with bronchiolitis, and also washing our hands frequently with soap and water as well. That was all in there. Clinicians should inquire to the exposure of tobacco smoke, and this is a big one. They talk a lot about making sure that you're talking to families about whether they're exposed to tobacco on a regular basis. And many of us do this, but it's a hard conversation sometimes to have with these families when you walk in and you smell the whiff of smoke and you're thinking, I can't even breathe. And you need to talk to them. Their child is sick with bronchiolitis and you know they're smoking around them. And this is when we really have to talk about, your child is sick, your child is gonna get sicker if you smoke in the house with your child. You need to smoke outside, no smoking in the car, all that kind of stuff. As well as, in the primary care settings, really encouraging breastfeeding through 6 months. This really helps to decrease the risk of severe bronchiolitis. We see they have strong evidence related to that. It is a moderate recommendation, so talking to that when you're doing the counseling with families, trying to encourage them to, especially during respiratory season, breastfeed through respiratory season. And then clinicians and nurses need to educate families and personnel on the current evidence related to the diagnosis, the treatment, and prevention of bronchiolitis, making sure that they understand this. In those children who are preemies, following the guidelines related to when they need Synergist. All right, so moving on to other respiratory illnesses outside of bronchiolitis. So there was a huge update in this diagnosis and treatment of respiratory illnesses of children and adults. I found this one to be in a very extensive guideline review. This one included everything from the basic URI through pharyngitis, through when do you worry about sinusitis. So we're just going to talk about a couple of the highlights of this one because I'm also going to talk about strep, pneumonia, and as well as bacterial sinusitis. So one of the aims of this one is to increase the percentage of patients diagnosed with viral URIs who receive appropriate treatment. This again is getting back to your antibiotic stewardship. Children with general URIs do not get treatment with antibiotics. I am surprised at the number of people who still prescribe. They'll come in, and I know it's based on some of the area that we live in. They have seen their doctor out in way east of Cincinnati, of the main hub, and they will be placed on an antibiotic for their URI. And you're like, did they have an ear infection? Because now they're coming to see me because the child's not any better. So this is when we have to spend some time going over, antibiotics don't really help URIs, if it's a virus, all that. We need to make sure that when we have children who have sore throats, really actually treating them if they have strep pharyngitis by rapid strep or culture. It is not appropriate, and this guideline is very explicit in this, to treat patients if you do not have a positive test. And then making sure that we give family really good education about the treatment for strep pharyngitis, as well as other pharyngitis care, using saltwater rinses, taking acetaminophen or ibuprofen to help with their sore throat. Because again, the families think every sore throat is strep. And then the use of corticosteroid therapy was one of the things that they were trying to decrease the use of as well in allergic rhinitis. So diagnosis of any kind of upper respiratory tract infection, whether it be a basic URI, cold, or all the way into strep and other types of things, is really based, again, on your history and physical examination and assessment of symptoms. I can't stress how much all of the guidelines talk about this. The evaluation by a provider for symptoms, looking also at what complicating factors do they have. Are they a child who is more susceptible to other illnesses? Are they neutropenic? All those other things need to be taken into account as well. It really stressed rapid strep tests and strep culture are the only surefire way to know when a child has strep pharyngitis. It talked a little bit about some nasal smears and when do you get those and when is that appropriate, and then it talked a lot about differential diagnoses. So a lot of the treatment and management around URIs, they focused on looking at education for families. They talked a lot about comfort measures in this guideline, using suction for infants, steam, mist inhalation. It talked about what was appropriate and what wasn't, and what had strong evidence and what didn't. It did go over a lot of the different types of medication therapies and what was recommended and what's not. And this is all the different things that this guideline talked about. So it talked about from over-the-counter, and I'm not saying these things are all recommended, but it gave you what the recommendations are. And this is like I said, this is a very long, extensive guideline, so my recommendation to you is look at it, read it. It talked about, it even discussed the use of the nasal strips, which I thought was funny. It gave a lot of information about home care. It talked a lot about allergen avoidance, etc. So the big outcomes for this guideline was, again, trying to decrease the rate of inappropriate antibiotic usage, trying to decrease cost of care for families, looking at a lot of the specificities, sensitivities, and predictive values for different diagnostic tests, and then talked about some of the adverse effects of different medications that people tend to use because a family wants the magic fix. So some of the major recommendations that I did pull out of this one are patients and parents and children who present or call with symptoms suggestive of a common cold should be evaluated for other symptoms and the presence of more serious illness. So, when they call about it, and they come in, they do need to have an evaluation. The primary treatment, though, for viral upper respiratory tract infection is education-based. Its education should take place via the clinic, via the telephone, at the work site, in various newsletters, posting things about what are colds, what are flu, that kind of stuff. And then patients and or parents should receive home care and callback instructions. We need to reduce the use of unnecessary antibiotics, and I know I keep saying that over and over, but it's a fact. Antibiotics should be used to treat bacterial infections only. The diagnosis, again, of group A streptococcal pharyngitis should be made by laboratory testing rather than clinical diagnosis. And just the other day, I had a child who came into one of our urgent care sites on Sunday before we left for the conference. And the mom's like, 2 days ago, we went to this other urgent care. It wasn't a children's-based urgent care. It's just one of the mom and pop ones that are around the area. They looked in his throat and they said, he's got strep. Put him on antibiotics. He's 2, by the way. Put him on antibiotics. And then mom and dad are now in our urgent care saying he's not better. So I did, I talked about recommendations. I talked about this is probably not the right treatment for him. I strepped him to give the family. I said, I'll strep him here, and we'll send it for a backup test, but I really suspect that this is all viral. He had very exudative tonsils, but he had no palatal petechiae. He was definitely still febrile. I mean, we've been seeing a lot of that lately. And he was also under the age of 3. Parents should be educated as well, as I talked about before, about if they are diagnosed with strep, and it's by culture or by rapid antigen test, they need to make sure they finish all their antibiotics. I can't tell you how many families tell me that they didn't finish their antibiotics when they come in, 2 weeks later and the child's sick again. And then making sure that we treat patients that are also have allergic rhinitis symptoms, making sure that we're giving them clear guidelines on when to restart their allergy medicines. You see a lot of that flare up as we're moving into the spring, and families forget they need to start that a couple weeks early before we actually hit springtime. So, and then one of the other big recommendations was it talked about when do you actually get a sinus CT when you're concerned about sinusitis, and the recommendation is actually not until children or patients have had over 3 weeks of antibiotic therapy and they're not getting better. All right, so we've talked a little bit about strep, and we're going to talk some more about it. So one of the big things with this is that as strep pharyngitis, the recommendation that came out in 2012, and its target population did include adults and pediatric patients. So, and I don't treat adults because I'm a PNP, but I did find this interesting that swabbing the throat and testing for group A strep pharyngitis by rapid antigen, test and/or culture is the norm. We should be doing that. But backup cultures are not actually recommended in the adult population. I don't do adults, so I don't realize that. But that is the recommendation. We only need to do it in children. And then ASO titers, the anti-streptococcal antibiotic titers, are really not routinely recommended at all. We need to make sure that follow-up post-treatment cultures, again, not really necessary. I had one child, and this didn't make any sense. This was just a few months ago. It was a child less than 1. The pediatrician or family practice doctor, I couldn't decipher which, kept seeing this baby and kept testing them for strep and retesting them, and then kept retreating this child. And first of all, the child was under the age of 1. And secondly, there's no evidence that that is a good practice. And I couldn't figure out what was going on. And of course, then again, they show up to visit us in the ED/urgent care. And we're like, what? And the child's sick again. And I really feel like the child just had this, continual, kept getting URIs, was in daycare, and for some reason was testing positive. We don't know why. So, and then diagnostic testing or empiric treatment of asymptomatic household contacts of patients for acute streptococcal pharyngitis is actually not recommended routinely, which is kind of a difference from before. There used to be a lot of information out there about treating those treating household contacts, or, it's definitely not treated. And the families always ask this question too. Well, is little Johnny going to get it? Because he's got it, and then that's when we go over how are you going to prevent it. I talk about throwing toothbrushes away, all of those things. All right, so treatments of choice. And I know yesterday in the lecture and some of the posts it was cute. Amoxicillin, amoxicillin, amoxicillin. Back to the bubblegum flavored medicine. So penicillin is the best treatment, but it's not, we don't treat it with the same dose that we use for otitis media. So, it is supposed to be 50 milligrams per kilogram. And, that's a difference for people because you're so used to treating high-dose amoxicillin for otitis. We don't necessarily need to do that for strep pharyngitis. It is found that 50 milligrams per kilogram, max of 1 gram, is appropriate treatment. We can use first-generation cephalosporins in patients who maybe have a penicillin allergy, like they had the little roseola-looking rash, which they all tell you about, as long as you don't believe they're going to be anaphylactically sensitive to penicillin, like they didn't have anaphylaxis from penicillin. Clindamycin is another decent treatment, clarithromycin, and this is the one time that I do use if I have a child with a penicillin allergy and there's a concern for cross-reactivity with the cephalosporin, that I will use azithromycin. But the dosing is different. It's not the 10 and then 5. It is 12 milligrams, for 5 days. We still talk about avoidance of aspirin in children. It's very important that they're using either acetaminophen or ibuprofen to help with their symptoms. I always tell families with just basic oral antibiotics, the child's not going to feel better probably for at least 48 to 72 hours. I make that very clear to them because they think like after 2 doses of medicine they're going to be better, and they're not. And then there's some information about tonsillectomies to help reduce the frequency of group A strep, and there's really not a good recommendation for that. There's also not a good recommendation for using any kind of corticosteroids, like giving them a dose of Decadron or giving them prednisone. There's really no good recommendations for that as well. And this is just a quick chart. This is actually a chart. I was hoping it would come up better. It didn't come up very well, but it goes over all the current recommendations and antibiotics. And if you have access to things like UpToDate in your practice or in your sites of work, this is a really helpful, this is where this chart is from, and it's very helpful. So again, making sure that you're treating with 50 milligrams per kilogram a day for amoxicillin, or divided twice a day, so 25 milligrams per each dose. And it talks also about what the dose of the LA bicillin is. It's easy. To me, greater than 27 or 60 pounds, they get the high dose, they get the 1.2 mLs. Less than, they get the 600,000. So acute bacterial sinusitis, this target population for this one was 1 to 18. So it's interesting because this was not an all-inclusive up through adults. So this one talked about diagnosis through physical examination and evaluation of symptoms, and especially length of symptoms. And then only getting CTs or MRIs when the child is suspected for having orbital or a central nervous system complication. So it's not routine to jump in and say, oh, you've had sinusitis for 3 weeks, let's get a CT. Management can be a couple different things. So if you think someone has acute sinusitis, you can do outpatient observation for 3 days with this new guideline and see if they start to get better. Is it really the end of a cold? This is a discussion you have to have with the family too. Or you can go ahead and begin antibiotic therapy if you feel like it's been over that time frame. So they recommend that so clinicians make the presumptive diagnosis if acute respiratory tract infection presents with persistent illness or daytime cough lasting more than 10 days, or worsening course such as new onset nasal discharge, daytime cough, and fever after the child started to improve and then got worse. And then one of the other things is severe onset concurrent fever, purulent nasal discharge for consecutive 3 days in a row is one of the other recommendations of when you start to treat for acute sinusitis. That's a little different than the way we used to do sinusitis. We used to wait always until kids are like over 2 weeks. So there's some changes in this one. The recommendations are starting again with amoxicillin. You can choose with or without clavulanic acid, or using high-dose amox with clavulanic acid, so the high-dose Augmentin, like the high-dose Augmentin ES. And then for patients who are sensitive to have that possible anaphylaxis or they're allergic to penicillins, again, staying away from Zithromax. You want to do clindamycin or cefixime, or they talk about linozolid, I can never say that one right, or cefixime, or levofloxacin, which these are very similar to the same medications and recommendations when we talk about pneumonia. And then making sure that we're reassessing for the management and seeing if the patients are improving. All right. I think I'm going to skip over otitis media because I know this was discussed yesterday. There's not a ton of changes in this. Again, using correct antibiotic therapy, reassessment in patients with who don't respond in 48 to 72 hours is important in this one. It talks about what the recommendations are for tympanostomy tubes, or PE tubes, for recurrent otitis media, what the diagnosis should be. So, I feel like this is interesting because one of the things that I did pull out of this one is that clinicians should diagnose acute otitis media in children who present with mild bulging of the TM and recent or onset of ear pain. Well, that's really hard in children who don't tell you that their ears hurt yet. But they do talk about holding, tugging, rubbing of the ear in a nonverbal child, or if you see intense erythema of the ear. Now, they did say that's a grade C. Recommendation strength, though, is, and the evidence is kind of in that middle. So I found that interesting because in the past, you had to see really purulent, erythematous, bulging TMs, and really feel that this was a otitis media. All right. So we've talked about this a little bit. Fever to 102, also with the presenting symptoms, myototalgia for less than 48 hours. There is some recommendation that we should be treating. And then clinicians need to think about either they prescribe antibiotic therapy or offer this close observation follow-up with some joint decision-making with families. This is kind of a newer thing. This was talked about a little bit more in the older guideline, and now this is a little bit stronger recommendation. It's grade B recommendation evidence in this newer guideline. So in your children who have symptoms with ear pain, less than 48 hours, some fever, it's appropriate to observe them and bring them back and have them look at it. If symptoms are getting worse or they're failing to improve after 48 to 72 hours, then it's appropriate to start antibiotics. But it's hard. Some of these families don't want to listen to that. In my case, I can't say I'm going to see you back in the ED in 2 days if they're supposed to go back to their primary care. So, and those are considered like unilateral. If you have bilateral, it's a little bit different. That's when they really do say that you need to treat. All right, so some of the other action statements, amoxicillin is still our, when appropriate treatment, when that's our decision to treat. We need to make sure that the child has not received amoxicillin, and they now say in the last 30 days, or if they don't have this concurrent purulent conjunctivitis, or that the child's not allergic to penicillin. So if they have concurrent purulent conjunctivitis, you need to move to something else, such as something that has beta-lactamase coverage. And that's discussed in this guideline as well. All right, clinicians should not prescribe prophylactic antibiotics to reduce the frequency of episodes of acute otitis media. I don't see that as much anymore. I do feel like several years ago, we were still seeing that after the first guideline came out. That was definitely one of the late other recommendations from the other guideline to stop doing that prophylactic treatment. And then I found this interesting. So you can offer the tympanostomy tubes for recurrent acute otitis media if they have 3 episodes in 6 months or 4 episodes in a year with 1 episode in the preceding months. All right, and then prevention. And the talk yesterday about immunizations was excellent. Again, getting these kids to get their vaccines. Vaccines do help prevent this. We know that. Making sure that they're getting pneumococcal vaccine, encouraging families to get the influenza vaccine, because we know otitis media is a complication of both of those things. And this helps to decrease. Talking to families again about breastfeeding for more than 6 months, and talking about avoidance of tobacco. All right, community-acquired pneumonia. Now, I have to say, I have the luxury of working in the Division of Emergency Medicine at Children's in Cincinnati, where when there are big guidelines that affect us in the emergency department, we do these clinical practice updates where we actually come together and they do a whole big update. So a lot of this information is from that update where we all sat down and we talked about the guideline. But it really helps because we want to make sure that we're doing our practice appropriately. So it is defined as an acute infection of pulmonary parenchyma in a patient who has acquired an infection in the community as distinguished by acquired or nosocomial pneumonia. So there are a lot of viral presentations of children with pneumonia, and the new guideline talks about that. So it can develop over several days. You can get have a URI infection first. There can be some just general diffuse findings on exam. They can have a cough with a low-grade fever, and usually they're not toxic looking. If we see kids with this, we should not be treating with antibiotics. So one of the things when you're thinking about pneumonia, you want to think about some of the common etiologies of pneumonia. And or the common ages as well as the different types of causes of pneumonia. So when you think about the age of a child, if you are concerned about pneumonia in that birth to 2 weeks, CMV, HSV, and rubella are our concerns. When we see the older, but less than 2-month age child, we think more about RSV, adenovirus, influenza, EBV, and parainfluenza. These are all the viral causes too. And then the 2 months to 3 years, again, RSV, parainfluenza, adenovirus, influenza, EBV. And then as you get into the older ages as well, you see more influenza and adenovirus. And we do see viral pneumonia in all of these age groups. So usually our bacterial presentations that we see are more abrupt onset. They have other contact with children who are sick. They may even tell you, oh, so-and-so in their classroom has pneumonia. They have high fever with chills. Their respiratory rate is increased. Their cough sounds wet. They are tired, less active, and have a decreased appetite, and often will complain of some chest and abdominal pain. So again, thinking about the common etiologies for pneumonia in the various age groups is very important. So the younger they are, the more they're going to be susceptible to different types of bacteria. And so we see definitely more group B strep, E. coli, and other coliforms, as well as listeria in that birth to 2 weeks. Then we start seeing some other things such as strep pneumoniae, and you may see chlamydia in that 2 weeks to 2 months. But then as you get to the 3 to 12-year-old, as well as the 13 to 19, you see more strep pneumo, maybe some mycoplasma. You can see H. flu in that 3 to 12-year-old age, as well as a little bit of staph. So when to treat? The guideline talks about, chest x-rays are not perfect. They lag behind often by 24 to 48 hours. So it talks about if you hear focal crackles and abnormal breath sounds with fever and focal respiratory signs, that's probably bacterial pneumonia, and they need to be treated, regardless of whether you get a chest x-ray or not. And then obviously, if you did get a chest x-ray, that the findings are consistent with pneumonia. So the guideline for the admission piece of pneumonia is children who are hypoxic, so their O2 sats are less than 91. Any signs of dehydration, whether it's severe or moderate, and they're failing IV therapy, with failed IV therapy, they will need to probably come in. Anyone who has a complicated disease, if you get a chest x-ray and you see a pleural effusion, or the radiologist has read a pleural effusion, I can't always see those, or the child's in any type of respiratory distress, they probably need to come in. And then anyone who's actually failed outpatient antibiotic treatment probably needs to come in as well. And then making sure that the clinician as well as the caregivers are comfortable going home and you feel like it's safe, or if it's not safe, then maybe they should come in. So when we treat inpatient, we actually treat them, we're seeing they're having high levels of penicillin resistance. So, but we do recommend, if there are not in your area, ampicillin is the preferred medication right now to treat. So we do IV ampicillin for patients who have concern for pneumonia, unless you're seeing a lot of resistance in your area. And that's something to know about. What is your area? Everybody years ago used to get ceftriaxone every time they had pneumonia. That's not the right treatment anymore. They get IV ampicillin. So if we think that there is resistant strains, they may do ceftriaxone, but they still feel that by cost, ampicillin is a better choice, and it is a more narrow spectrum. So there's a lot of talk about whether we use azithromycin or not in empiric treatment. The only time we are using azithromycin is if we have is if we believe that there is also a chance that the patient has a mycoplasma pneumonia on top of it, but we do not just use azithromycin. We would do ampicillin with azithromycin. So there's a lot of pneumonia or significant pneumococcal resistance that they have found to macrolides, and the macrolides are recommended, like I said, or not recommended for empiric therapy. And the macrolide is associated with a selection of resistant organisms. So we have really gotten away from using azithromycin. So the Infectious Disease Society Association recommends that for all inpatients, ampicillin or Pen-G is where we start, especially for fully immunized school-age children that get admitted to the hospital. Third generation cephalosporin could be used if you have patients who are in regions of high-level penicillin resistance, and also considered for patients who are not fully immunized. So, we do still see those. Vancomycin or clindamycin can be added in addition to the beta-lactam therapy if clinical, laboratory, or imaging characteristics are consistent with an infectious cause such as Staph aureus, because those kids can get extremely sick extremely fast. All right, so we're going to talk about some other things related to the management of infants greater than 3 up through school age. So again, viral pathogens are responsible for the majority of diseases. A lot of it is RSV, adenovirus, rhinovirus, parainfluenza. The recommendations vary strongly in this. If we believe it's viral, it's supportive care. Consider doing a flu testing and treatment for flu if it's flu season. And that is a recommendation that is highly in the guideline. Most bacterial causes are strep pneumo, again, but not group-based strep and H flu. So the recommendations in the guidelines are to do amoxicillin, as well as if you're doing inpatient, again, doing ampicillin. So I have your doses on there so you know what your dosing is. So the dosing for amoxicillin outpatient is high dose, just like you do for otitis media. All right, school-age children. So it is same as the previous slide that we talked about, but if you are considering and you are concerned that they have an atypical bacterial pneumonia, such as mycoplasm, you can add azithromycin, but you are supposed to treat with both. And I still see patients come in with just treatment with Zithromax. And then the dosing is the 10 for the first day and 5 for the second day. All right. Unimmunized or critically ill. We kind of touched on this before. These patients should be treated with ceftriaxone, inpatient, as well as possibly vancomycin. If they're going to be outpatient, then the recommendation is actually to use Augmentin ES if they're unimmunized and they're going to get to go home. Some other things to consider, again, if you have penicillin allergic patients, you want to use ceftriaxone if it's inpatient, clindamycin if they're going to go home, they could possibly get clindamycin, and then levofloxacin is another option, and I have used that in a few kids who have penicillin and cephalosporin allergies. The dosing is kind of strange in this one, so you need to make sure you're paying attention to your dosing, because it goes age 6 months to 5 years, and then it goes 5 years to 10 years, and then it's 10 years and older. So the only real diagnostic testing that they talk about for outpatients is checking their pulse ox. You want to make sure in your office you've checked a pulse ox in a child you are writing on your chart has pneumonia. Admission should be indicated for patients that are previously healthy and then their oxygen saturation is below 90%. Some people will hospitalize for children who are less than 93%. So those children do tend to look sicker if they're around 93% or lower. And again, this is just the recommendation, exactly what I was talking about. Pulse oximetry should be performed on all children with suspected pneumonia, making sure that you're documenting what their pulse ox is. It drives me crazy when we have kids who come in with cough and URI and nobody got a pulse ox in the ED, which is like a simple thing, or the urgent cares. I'm always going, can you please go get a pulse ox? All right. And then antimicrobial therapy is not routinely required for preschool-aged children with community-acquired pneumonia, and this was a big change from previous. If they are preschool age, their most common causes of pneumonia are viral pathogens. So if they have just those coarse breath sounds, they're pretty well appearing. To tell a family that they have viral pneumonia and you're not going to treat with an antibiotic, those families are like, what? So you have to have that conversation with them. This is usually viral, and this was a pretty strong recommendation, and there's high quality of evidence. So think about it. You know, really think about, how does the child look? Are they pretty well appearing? If they just have coarse breath sounds, you don't need to put them on antibiotics. You can bring them back to keep checking them, but if they don't have a focal site of pneumonia, it's probably viral. And wheezing is a big one with these kids. They will have like a wheeze. You know, so it is definitely usually more viral. Again, we talked about amoxicillin outpatient is our first line of treatment. Courses for 10 days. All of this has strong recommendations. And then the atypical recommendation, again, is macrolides prescribed for children in that primary school age and adolescent. If you feel that they have possibly an atypical, then you add it. But there's not a lot of good recommendation that you only use macrolides. So it's a weak recommendation even. All right, so we're going to move on and talk a little bit about febrile seizures. This one's scary to people. Everybody wants to test, figure out what's wrong with them. But the target population for this group is neurologically healthy infants and children between the ages of 6 months and 5 years who've had one, not multiple, one simple febrile seizure and presented for an evaluation in the first 12 hours after their febrile seizure. And the practice guideline is not intended for patients who have complex febrile seizures, prolonged, focal, or recurrent febrile seizures, and it does not pertain to the child who has had a previous neurological insult and already has central nervous system abnormalities and a history of seizures. So the recommendations that they want people to consider would be, okay, a lumbar puncture, but it's only supposed to be performed if a child has had a seizure and they have a fever and they're having meningeal signs. So that's something to consider. So your meningeal signs include neck stiffness, Kernig positive Brzezinski's signs, or a child's history or examination suggests that this child has some kind of meningococcal or intracranial infection causing them to have this febrile seizure. So that's just to be considered. Routine EEGs are no longer recommended. You know, there are some people who used to, every time a child had their first time febrile seizures, outpatient people would, you know, order an outpatient EEG. It's not recommended. And then blood studies. I can't tell you how many times we get a transfer for a febrile seizure, like a patient who comes from another outside hospital, and they've done this huge workup for a first-time febrile seizure of, you know, they've checked a renal, CALS, MAG, FOS, CBC, and then they send them to us to reevaluate the child, and the child just had a one-time febrile seizure, and you're like, okay. And the family thinks we're going to be the magic fix. So it's more of talking with this family and saying, you know, this probably wasn't all necessary. I mean, unless the child appears very ill, we shouldn't be doing any of those things. And then again, neuroimaging, they don't need skull radiographs, they don't need CTs, and they don't need MRIs routinely for a child who has appeared with a first-time febrile seizure. So clinicians who are evaluating infants and children who have a simple febrile seizure should direct their attention towards identifying what's the cause of the fever. So again, is the fever caused from a UTI? Is the fever caused from otitis media? Is the fever caused because they just have a general URI? It happens. But families think that there's like something really bad going on if they've had a febrile seizure, and that's our job to go over that with them. Meningitis, of course, should be considered in our differentials for any febrile child, and then they should have an LP performed. We cannot determine meningitis from just getting a complete blood count. The only way to test for meningitis is through an LP. And that's for those children who are ill-appearing, that we should consider that. Otherwise, it doesn't need to be considered. If, though, you have a child who maybe is deficient in some of their immunizations, again, that might go a little higher on your list if you're concerned about that and can't find a source for their fever. But in general, a simple febrile seizure does not usually require any further evaluation, any EEGs, any blood studies, or any neuroimaging, is what the basics of that guideline came out with. All right, moving on, we're going to talk about UTIs. So UTIs, this one is interesting because this one stopped at 24 months. Well, it didn't give us any information over and above, so we're just focusing on the 24-month range, 2 to 24 months. So it talked about diagnosis, it talks about treatment management, and it talked about major outcomes that we needed to consider for UTI infections. So again, getting a really good history and physical examination. There are some gender-specific risk assessment things that we needed to think about in this one. Urine collection should be by catheterization in children who cannot, most of this age group, they cannot urinate on their own until they're over 24 months. If they really can pee on their own, then you can try a clean catch, but it's got to be a really good clean catch. Or they say suprapubic aspiration. I don't remember the last time I saw a suprapubic aspiration on any kids in the ER. Most of the time, we do catheterization. Getting a good urine culture as well as a urinalysis. So a febrile infant with no apparent source of fever that may require some antibiotic therapy who is ill-appearing should definitely get a urine specimen. So the recommendation is that if they're over a couple days of fever and they have no signs of any type of infection, otherwise, then you need to be checking urine. All right, management. So the recommendation for management is either IV or oral antimicrobials. They do talk about what the length should be. So they talk about choosing anywhere between 7 and 14 days in duration for antimicrobial therapy. It does talk about the initial route of consideration is based on how well the child appears. So you can do oral. Oral is fine, but if you feel the child is much more ill, then they may need IV first. One of the big changes that I do recall in this one is that they do recommend getting renal and bladder ultrasounds in kids who have febrile UTIs once they're improved. But VCUG is no longer indicated the same as it used to be. So they feel that avoiding VCUG should not be routinely performed after the first febrile UTI, but it can be indicated if the renal and bladder ultrasound are abnormal, or if it shows any hydronephrosis, scarring, or other findings that the child may have a high-grade reflux, then they want you to consider getting the VCUG. But that's a little bit different than in the past. You know, we used to, every febrile illness or febrile UTI got that routine renal, bladder ultrasound, and VCUG. So that has changed over the years as well. All right, last thing, and then we'll have some time for questions. So STIs. This is one of my favorite things that I found when I was investigating this. So there is an app. There's an app for everything, isn't there? There's an app on that you can put to your phone that has the latest CDC STD treatment guidelines. So, and the guidelines are pretty extensive. It's like 64 pages long, But the actual guideline, you can read the guideline. You can just pull up various parts of the guideline, like they have an app for it, of the different parts of it. So I found it to be very interesting and actually put it on my phone just so that I could use it, because I see a lot of STIs in the ED and the urgent cares. So this is a very new guideline. It's new and updated. It's from 2015. And it's very important that we are all aware of it and know what the guidelines are. So since this is my last part of my talk, I was thinking I was going to run out of time. And so I didn't go over every little piece of it. But if you download it onto your phone, you can read all the extensive stuff of it. So basically, in the new guideline, it talks about alternative treatment regimens for Neisseria gonorrhea. Right now, the recommendation is to do ceftriaxone, 250 milligrams IM, plus 1 gram of Zithromax. They are saying now, and we got away from it for a while, that you can do Cefixime, 400 milligrams orally again, with some Zithromax, but there is a chance that the patient will not be treated well. So we still try to do the IM injection of ceftriaxone. They do recommend there is some new information about using the nucleic acid amplifying, or the NAT test, for diagnosis of trichomonas, that it is a much better test than the old culture way we used to do. And then there is some talk in there about yes and no for boys. So that's still the jury's still out on that one. There's a new alternative treatment options for genital warts, and I would recommend, if you can put the app on your phone, that you can, and there's an app for both Apple as well as Androids, that you look at that, because that's different than in the past. There is some information about the role of this new Mycoplasma genitalium in urethritis and cervicitis, which is kind of a newer STI that they've found in the 90s, and they kind of were ignoring it, and now there's more talk about how do we need to treat this one. As they talked about yesterday, HPV vaccine recommendations, and then making sure that all the recommendations on there are updated in this guideline. Making sure that we know about how do we manage patients who are transgender. There's a whole section on managing transgender patients. And then some discussion about annual testing for hepatitis C as well in patients who are HIV infected. And then there is some updated recommendations on diagnostic evaluation for urethritis. And then finally, there's some information, a whole section that talks about when do you retest to detect if they have repeat infections. So for me, some of the most important things, I think, related to clinical practice guidelines, and I know this is dry information, trust me, it's just really important that we are aware of them, that we have read through them, we know what's going on, we make sure our practices, wherever we practice, are following those guidelines, that we're not doing something that the guidelines recommend and your colleague in the room next door is doing something else. We as PMPs need to make sure that we're all following the guidelines the same. I know they are just guidelines. People will go outside of guidelines, but if the practices aren't the same, then there's this piece of families don't understand, standardization of care is very important in where healthcare is moving. And if, your practice is not practicing the same and following standard of care, then families get really confused. Because they'll see one provider who does it one way, and they'll see another provider who does it another way. And so for us at Cincinnati Children's and in our ER, we are really trying to standardize care and make sure that we are following guidelines, we are following recommendations, and that we all are doing it the same way. Making sure that you're aware of when changes occur. I can't believe how, you think that you're up to date, and then all of a sudden the guideline's been revised again, and it may just be a little tiny piece that's been tweaked in there, but you need to be aware of it and know what it is. So read articles, follow what's going on, and making sure that you're staying current. I think that one of the things that we can do as advanced practice nurses is, now we have all these EMR systems, utilizing the EMR systems to make our practices better. We have developed discharge templates that actually have a lot of the recommendations of different antibiotics in, like, so if you have pneumonia, the correct antibiotics are in that template. You know, same for some of our treatment and management plans. We actually have, you know, templates that you can pull up that will actually be exactly what the guideline recommends, and you can then choose your dosing based on the age of the child and all that kind of stuff. So I just really think, you know, get with your, whoever are your EMR representatives and say, how can we make this better so that we are all standardized and people know what the practice should be and know what to choose from? Because there's a lot out there, and it gets really confusing, and it can get muddied very easy. So I want to thank everybody for your attention. And I'm finished. If you have any questions. Yes. 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 So in the guideline, it talks about, it doesn't talk specific to ages, but it talks about the types of symptoms. So if you have that, you know, they have persistent symptoms for over 3 days with purulent discharge and high fever, you know, and that daytime cough, then they say you should treat. But it's really hard because you're right, infants have these itty bitty bitty sinuses and really do not get sinusitis. I mean, if you talk to the ENT doctors, they're like, that's a bunch of bull. They're going to develop conjunctivitis and otitis before they, and that's what I usually explain to families. You know, really under 1, they come in and their version of sinusitis is they've got conjunctivitis and otitis together after they've had a horrible cold. But I very rarely treat any of those young infants or even up to age, you know, 1.5, 2 for sinusitis. It really talks about, it's more the older, older toddler preschool age. The symptoms have to be persistent. If they're not febrile, I'm like, they've got a cold. And also telling families think coughs should be gone in a week. There's a lot of good articles out there that talk about coughs last for weeks in these infants and toddlers after they've had a URI. And that does not mean they have sinusitis, but families think that they need an antibiotic. So just trying to follow all those, you know, and talk about standard of care with the families and making sure your colleagues are doing the same, I think is really important. But the ENT doctors are like, sinuses really do not develop well until they're over the age of 1. So, yes? Yeah. I think for us at Cincinnati Children's, we follow more AAP guidelines, okay? As a group, we talk about what guidelines are we going to follow. So we do more of the Infectious Disease Society of America / because some of them have actually kind of combined a lot of their guidelines, which is great, you know, because you're right. When we first came out with guidelines, everybody had their own, including Cincinnati Children's. It drove us all crazy. But the other piece to it that's really hard is you have to think about what's happening in your area as well. So there is some, you know, it's a guideline. So you do sometimes have to veer away from that guideline because of what is the infectious disease in your area, like what is the resistance to something. For us, though, we as a group decide what guidelines we're following. You know, we're going to follow Infectious Disease Society of America, and AAP is what we tend to gravitate to at Cincinnati Children's. So I think it's really important to talk with your group and know what is it that they agree on. Does that make sense? Okay. Others? Yes. Let me go back. It's on like the CDC website. Oh, it won't let me go back. It just says STD treatment, but if you go to the CDC website, you can download it right from there, I think. Or it opens it up to then go to your app store. But I think it was just called STD treatment. I don't have my phone up here, or I'd tell you. Okay, CDC STD treatment. Oh, now it went back. There. Yeah, CDC STD treatment. Okay. Anything else? Yes, Jody? I think so. I haven't heard, I mean, as you know, we're using Decadron now for asthma too at Cincinnati Children's. So, and I'm not faulting that. I think there is evidence out there. I think this is something new they must be trying because there's not a good Croup guideline out there. The only one I could find is in Canada. So that's where we had that BEST statement, and you can find it like on the National Clearinghouse guideline site. But I don't know about inpatient. I haven't heard about that. Any others? I hope this was helpful.